Assalamualaikum. My name is Mohammed Nasr. My roll number is BP1650115. I am from final year morning. I am submitted to my assignment to Ma'am Shahana of pharmacy practice, and my main topic is cyclophosphamide. So firstly, we know that what is cyclophosphamide. It says we all know that it is an mustard agent and it is an alkylating agent which act through hydroxylation of cytochrome P450, and it is broadly used as in various regimens to treat neoplastic diseases like non-Hodgkin lymphoma, sarcoma, and breast cancer. Its mechanism of action, as we discussed it previously, that it is an alkylating agent, so it hydroxylates in liver by cytochrome P4 system, and it produces intermediate products by breakdown of active compound, and is there phosphoramide mustard and acrolein. Phosphoramide mustard react with DNA, it inhibits these neoplastic cells and its primary metabolites, and the parent drug are excreted through urine. What is irrational and rational use? As we know that the term rational use means beneficial use and the term irrational use means non-beneficial use. So rationally it is used in various types of treatment as a chemotherapeutic agent in order to slowing or inhibiting or stopping the cell growth, and it is also used by decreasing your immune response to various diseases. And irrationally, it is used in many blood disorders, liver diseases, kidney diseases, allergic. Avoid touching eyes and inside or without washing your hands or duration for this treatment. Indication and adverse effect. Indicatively, it is used in the treatment malignant lymphoma, multiple myeloma, leukemia, acute myelogenosis, monocytic leukemia, lymphoblastoma, leukemia, mycosis, fungoids, neuroblastoma, adenocarcinoma of ovary, retinoblastoma, carcinoma of breast, and adversely it is used in hemorrhagic cystitis, which can lead to fibrosis of the bladder, which has been attributed to acrolein in the renin, GI distress, myeloma suppression, and alopecia. It is also cause cardiac dysfunction, pulmonary toxicity, and syndrome of inappropriate ADH secretion. Drug interaction. It is greatly interacted with other drugs like acetylsalicylic acid, which is commonly called aspirin, doxorubicin, which is also called adriamycin, neulasta, which is called pyrifilgastrin, amand, apretant, zofran, ondansetron. Drug toxicity with mechanism. It is greatly resisted as a number of interleaving factors in which the main reagents are glutathione and DNA repair process to cyclophosphamide resistance. Glutathione appears to involve directly to the detoxification of cyclophosphamide and metabolites and play a more indirect role of other processes. It means that when glutathione is when the DNA and glutathione react with each other, when the cyclophosphamide is also acting, it inhibit the cyclophosphamide induced DNA liaisons and nucleotide excretion repairs or other processes, and it is a key contributor to drug resistance. And it is also interestingly the presence of repair enzymes 6-alkyl-gluconeogen and alkyl transferase, long thought to be involved in resistance of methylating and chloroethylating agent, and also contribute resistance to cytotoxic and mutagenic effects of cyclophosphamide. Dosage and administration. And we know that the cancer are of two types, malignant and benign. In benign, they are not benign diseases are not of it so much. Although it is cautious as it is a cancer, but in malignant diseases they are very very severe as compared to benign diseases. So in malignant, for adult and pediatric, it is available intravenously, orally. In intravenously, we given 40 mg to 50 mg per kg for a dose of 2 to 5 days. When, as we discussed, that the cyclophosphamide was greatly used in regimens, so it is used also in regimens, but in regimens the dose may be lesser than that of separately. So its dose is 50 mg to 15 mg per kg given 7 to 10 days, or 3 mg per kg to 5 mg per kg twice weekly. And orally, it is 1 mg per kg per day to 5 mg per kg per day for both initial and maintenance dose. In non-Hodgkin lymphoma, it is given 600 to 1500 mg per meter square IV with other neoplastic, and in breast cancer, it is available 600 mg per meter square IV with other other anti-neoplastics. Dosage, form and strength and route of administration. It is available as a powder and a tablet form. So we have word in mind for what the purpose of powder form. So basically, for chemo patients in hospitals, it is not given, and actually it is given, but a dilution are not given to the paramedical staff like nurses or compounders. The pharmacist in the laminar flow hood dilute the drugs and given to the patients in order to reduce and less chance of contamination. So in powder form, it is available in 500 milligram, 1 gram or 200 milligram, and in tablet it is available in 25 or in 50 milligram. Oral route of administration. It is given orally, intravenously, intramuscularly or intraperitoneally also. What is the alternative choices? As when the patient is resistant to cyclophosphamide or some chances of detoxification, in short, the patient for cyclophosphamide not suit when such a particular patient. So we have alternative choices also when which given to the patient like procarbazine, tamodas, sinu, bisulfan and alkylan, in which bisulfan and alkylan have various side effects and is given cautiously. So it is prescribed for very rare. Alternative brands of cyclophosphamide. Its brands are available like Zycram, Endoxin, Cyclomide. So and its manufacturer, drug form, packing, trade price and retail price I mentioned. So according to the patient compliance, we will prescribe the drug according to the patient need and how much they afford. Our main topic, that is case study. Our case is a patient having 57-year-old man with a 6-year history of chronic lymphocytic leukemia, which is in short called CLL, presented with a rising white cell count, worsening lymphadenopathy and hepatosplenomegaly. Treatment was commenced with oral fludarabine 40 mg per meter square and oral cyclophosphamide 250 mg per meter square daily for 3 days with rituximab. Here are the sources. Subjective is that patient age 57, gender is male, chief complaint is chronic lymphocytic leukemia, history of illness 6-year history of chronic lymphocytic leukemia. Objective is that all vitals are normal. The means her BP, sugar, cholesterol or uric acids are normal. What are the what is the assessment? As we notice that her lymphadenopathy and hepatosplenomegaly are worsening day by day. So here are our plan. As patient was given FCR regimen, means fludarabine, cyclophosphamide and rituximab, but we increases its cycle and increases its dose in order to reduce the lymphadenopathy and hepatosplenomegaly. We give 6 cycles of FCR regimen in which the fludarabine dose is 250 mg per meter square over 20 to 30 minutes on day 1 to day 3 and cyclophosphamide dose is 250 mg per meter square IV over 10 to 30 minutes on day 1 to day 3 and rituximab dose is 50 mg per meter square on day 1 to day 3. And here we notice that the patient has a high risk of immunosuppression. So we give an acyclovir as a prophylaxis in order to boost his immune system. So in short, we examine that the patient's condition are worsening day by day, so we increase its dose and its cycles in order to reduce its adverse effects and in order to decrease the neoplastic cells and try to prevent the patient's life. And we also given acyclovir or other immunosuppressant and to boost its immune system. Here are my references. We give the text from Lippincott Illustrated Reviews, Pharmacological 6th edition, Katzin and Trevers, Pharmacological 10th edition, and Pharmapedia Pakistan. And also we used internet and or social media reference sources like PubMed, iodine.com, drugsinfo.com and Medscape. And we also used Roger Walker Clinical Pharmacology book in order to find out my case study. That's all. Thank you so much. Allah Hafiz.